Providers using pulse oximetry to diagnose and treat hypoxemia must understand how the pulse oximeter works and understand the limitations to its accuracy. One major goal for most of our patients, whether stable or critically ill, is to maintain adequate oxygen delivery to all the cells and tissues in the body. Oxygenation is the process by which oxygen from the alveoli in the lungs diffuses into the pulmonary capillaries. Once oxygen diffuses into the pulmonary capillaries, the majority binds to hemoglobin within the red blood cells. The hemoglobin that is bound to oxygen is termed oxyhemoglobin. Pulse oximeters are one of the most valuable monitors in patient care. Pulse oximeters measure oxygenation indirectly and are painless for the patient. Pulse oximeters use probes to shine red and infrared light through tissue beds. Red light has a wavelength of 660 nanometers. Infrared light has a wavelength of 940 nanometers. Sensors in the pulse oximeter detect the amount of light absorbed at each wavelength. Through a process called photoplasmography, arterial blood flow is detected by its pulsatile flow. Pulsatile flow generates an alternating current, designated AC. Non-pulsatile flow in the tissues are canceled out. Non-pulsatile sources include venous blood and tissues. The pulse oximeter then calculates a ratio of oxyhemoglobin to deoxyhemoglobin in arterial blood only. This ratio is then displayed as a percentage on the pulse oximeter screen. The pulse oximeter comes with a probe and a computerized unit. The first step is to place the probe on the patient's finger, toe, or earlobe. In small children and infants, the probe may extend over the entire hand or foot. Next, make sure the unit is powered on. Some pulse oximeters require batteries or charging, so it is optimal to ensure adequate power to the device at all times. The pulse oximeter should display the pulse rate and the SpO2 or oxygen saturation. Many devices also display a waveform. It is important to check that this waveform corresponds to the patient's pulse or the electrocardiogram tracing. This will ensure the accuracy of the values being recorded. There is also an audible beep. That beep corresponds to each heartbeat. It sounds like this. Most pulse oximeters also have the capability to change the tone of the beep with changing values of oxygenation. The higher the SpO2, the higher the tone. The lower the SpO2, the lower the tone. Changing tones with changing SpO2 is called tone modulation. It sounds like this for an SpO2 of 100%. And it sounds like this for an SpO2 of 85%. There are several limitations to pulse oximetry. Most limitations lead to a falsely low SpO2 reading. Movement, shivering, and electrocautery interfere with the probe's ability to detect pulsatile arterial blood flow. Similarly, abnormal heart rhythms can interfere with the pulse needed for photoplasmography. Methemoglobin absorbs light similarly at 660 and 940 nanometers, which leads to an inaccurate ratio and usually an SpO2 approximating 85%. Similarly, many injectable dyes can also cause a false low SpO2 reading. Carbon monoxide leads to a falsely high SpO2 reading, as it absorbs light at the same wavelength of oxyhemoglobin.